Hello, I'm Commander Anil Shah, and I'm an otolaryngologist at United States Naval Hospital, Naples, in Naples, Italy. And for today's Tech Talk, we're going to talk about advances in Tele-ENT. Disclaimer, I have no relevant financial relationships to disclose relating to the content of this activity. The views expressed in this presentation are mine, do not necessarily reflect the official policy or position of the Department of Defense or the U.S. government. And the people in these videos are actors, and they have been consented to be examined for the content of this presentation. So for this Tech Talk, we're going to review some definitions related to telehealth and telemedicine. We'll talk about COVID, the big disruptor that kind of brought about telemedicine into its limelight, current use of tele-ENT in the military. I'll talk about some of my personal experience with that. Why should we advance tele-ENT, and who are we actually doing this for? Some limitations of the technology, and then we'll talk about some potential future applications and where we see ourselves going in the next 5 to 10 years. So let's talk about some definitions. So first, telemedicine is defined as delivering remote clinical services over a distance. And this can mean anywhere from video calls, audio calls, anywhere there's separation between the patient and the provider, and there's some sort of service being provided. Telehealth, in contrast, has a broader definition and includes often non-clinical activities such as education, admin, etc. So telemedicine is a little bit more specific to the care provided over a remote distance. Synchronous versus asynchronous. So synchronous is where you are actively engaging with the patient in real time, so providing care, actively um, discussing the treatment plan disposition with the patient, as opposed to asynchronous, where a patient could be an exam recorded and reviewed at a later date, or perhaps a consultation sent on behalf of a patient related to radiologic imaging or whatnot that is reviewed by a provider and then results provided at a later date. Host site versus remote site. So the host site is defined as where the patient's located. The remote site's where the provider's located. If they are even geographically in the same city, for example, you may have differences in locations between the patient and provider. And so these are just terminology to help delineate what kind of encounter is occurring. Video encounter, the patient can use their smartphone and be in communication with the provider remotely through audio as well as a camera encounter, as opposed to just an audio encounter, which is our typical telephone consultation. And then lastly, we'll talk about patient versus provider versus hospital centric. And that's where we'll go into the why of why should we advance telemedicine and what is our construct of how we're going to go about doing that. So first, let's talk about COVID. So telemedicine exploded, as many of you are well aware, during the COVID pandemic, brought about primarily due to some of the regulatory and legislative changes that occurred related to COVID. For example, there were restrictions of in-person visits, concerns obviously of spreading infection between individuals who are in close proximity to one another. And so telehealth, telemedicine really exploded as the CDC explicitly recommended pursuing these options in contrast to the typical in-person visits. Some of the more specific legislative changes that occurred include improved provider payments, allowance for providers to serve out-of-state patients. This is especially pertinent with licensing issues where you may be licensed in one state but seeing a patient in a different state, which license is important. And so allowing providers to still be able to see these patients who aren't necessarily in their state really opened the door for telemedicine. Different types of providers were allowed to use telehealth services, and there was permissions allowed for federally qualified health centers and rural health clinics to provide these services. One of the big changes, of course, is the increased telehealth reimbursement rates. As you're well aware, you're not going to, providers will not be, companies will not be providing teleservices if they're not getting reimbursed for the work that they're doing. And so that was a very important change. Between mid-March and mid-October of 2020, 24.5 million out of 63 million Medicare beneficiaries actually received a telemedicine service. So post-COVID, we've seen a huge growth of telemedicine, and this has really allowed for opportunity for how we provide care and beyond just the typical in-person visits that we're accustomed to. So in the military, Tele-ENT has actually been used for some time, and currently where I'm stationed, which is in Naples, Italy, there's 2 ENT providers, and we cover Rota, Spain, and Sigonella, Sicily. And we use the host site, which would be either Rota or Sigonella, has a telehealth clinic composed of a corpsman or medic and a virtual health nurse. And we see these patients virtually using the telehealth clinic carts, these global med carts, where the provider, the nurse or corpsman, presents the patient from the host site, and then we provide care, treatment plans and dispositions, and then we rotate at these sites every quarter, performing up to 12 to 15 surgeries as well as 50 plus encounters over a 2-week period. It's been a great program to allow for us to still see our active duty dependents and civilians at these locations, and we have the ability to provide video audio follow-up. So currently, we have what we're using is a synchronous ENT telemedicine setup. What you see in the slides are the typical global med cart composed of a monitor with a camera, and there's video attachments which I'll show here in a minute in terms of demonstrating the capability from the host site. But this is where the patient is located, for example, in Rota, Spain, or Sigonella, Sicily, as opposed to the remote site, which is where the provider is located, most commonly here in Naples, Italy. So the provider would sit in front of the computer, communicate with the patient and nurse or corpsman through the computer, providing a treatment plan. Here's an example of a visit.
25-year-old Jenny Hernandez. She's here because she has constant reoccurring ear infections. It's been going on for about 5 years. Usually gets it around 4 to 5 times a year, constantly on the left side. She comes in, they give her left ear. All right. Let's do your nostrils. Fog up the camera, okay? All right, so just look at me. All right, 1, 2, 3. The other one. Ready? Ready? 2, 1. Good. I'm gonna try that one more time.
So as you can see, the quality is fairly good, and we're able to really see the ear, nose, and throat on the examination, which helps us in our treatment plans.
25-year-old
So the big question is why? Why? How do we go about advancing this tele-ENT, and what is our framework by which we do it? So kind of broke it down into three categories: kind of a patient-centric focus, physician-centric versus the hospital. So from a patient perspective, if a patient's able to be examined, maybe have their appointment from the comfort of their home, they'll have reduced travel time. If it's their schedule, they could be remote, as in another country, another city, and still be able to interact with the ENT provider, and um, with the related to whatever complaint or problem that they're having. Um, it can be synchronous versus asynchronous. So synchronous, they can get an instantaneous report back from the provider after seeing them, as opposed to an asynchronous where they record their exam, submit it, and then get a response back, maybe in a delayed fashion. It allows for streamlined process, so potentially no requirements for a referral. You could just directly interact with the ENT provider. Customer driven, so you could upload your information into a secure database and get different provide different options from different providers based on what they see on the exam and what they could offer the patient. So really customer driven in terms of what they want to pursue. Potentially lower costs. So if you've got less ancillary staff, less physical locations and processes that are limiting, or that add to uh, the potential costs, it would be lower if you could all do independently through the technology. Potential downside would be more work for the physician if there's like technology issues, or booking or scheduling follow-ups or imaging or whatnot. That could potentially, if the system's not designed well, that could lead to more challenges in terms of providing the optimal care. From a physician-centric standpoint, once again, a physician can be asynchronous and can respond at their own time. There's not this time crunch on having to provide a response immediately. They can do some research if there's more information that needs to be obtained or reviewed prior to making a treatment plan. They can work from home or the office, so that would potentially lower costs. So if they're able to hypothetically be in a remote location and still provide care and consultation for these patients, it would improve access to care for patients because they could basically see them from anywhere at their own time. Allows for patient physicians. This process could screen patients to allow when for more complex care in person, and the more routine, simple options can be done through video or through these remote type situations. And then AI could be a valuable asset where algorithms could help manage the patients for the more common complaints, and then stuff that's more complex can then get sent to the provider to review, whether in person or virtually. Hospital centric, so now you can, kind of like Naples, where we have two ENTs in one center. Your equipment, your tech support, your stuff could be centralized in one location as opposed to redundantly multiplied at different locations. And then you basically bring the patient to the facility if needed. And so that can be a cost savings for the hospital. Having more advances can increase volume and access, which potentially means increased revenue. And once again, not having that ancillary support requirements may also improve cost. So some of the advances that are out there to allow for some potentially asynchronous or kind of at-home care is the smartphone. There's some apps already out there that can maybe test your hearing, doing an audiogram. Audiograms are required when ENTs evaluate patients with hearing issues. So we can review the audiogram and make some treatment recommendations based on that. There's a smartphone tympanometry. Tympanometry is where it's a pressure test within the middle ear to see compliance of the eardrum. This can be very helpful for pediatrics when you're suspicious that a patient has either chronic fluid causing hearing loss, or ear infections with flat tympanograms. And so this could either be performed at the host site, separate from the where the ENT provider is, and or even potentially at home, and recorded and then sent in and reviewed. So multiple options from the ear perspective. Um, if you, I Googled on Amazon.com, I searched for a phone and otoscope, and there's devices you can see fairly cheap to give you imaging of the eardrum. And this will allow, you can send these images in to get reviewed through you looking using AI or a provider looking at it, and they can provide treatment recommendations based on these findings. For the throat larynx, we use what's called fiber optic laryngoscopy, where we look in the nose and throat. You can train a staff member to perform this at the host site, and then the exam reviewed. So, for example, in this video, um, a tech can be trained to perform this exam, and then this exam can get reviewed with the patient. And so turbinate, septum, he's got a little spur there. So see, basically, the scope is just driving. I'm not doing hardly anything. See that? I'm just kind of gently guiding. Perfect. Now I'm at the nasopharynx, and now I'm turning the corner, so I'm pushing down this way. So I'm hardly doing anything. Doing great. Say E. E. Good. Big step in. Go. E. E. Okay. And then stick out your tongue for me. Perfect. And you can stop recording. So it's a great way for ancillary providers can perform this exam, like as mentioned, at a distant site, and this can be reviewed by ENTs. And then if there's a mass or lesion, certainly that can expedite the whole process for evaluation and treatment. Voice analysis. So when we look at the larynx or the vocal cords, a lot of patients may have various disorders such as adductor spasmodic dysphonia or a granuloma or whatnot. And so smartphone analysis of the voice can help with triaging and screening these patients. So there's lots of options in terms of what the smartphone capabilities are, remote host versus remote site, to really allow for the patient to get adequately examined um, to their convenience, and then have that reviewed and then acted upon kind of either synchronously or asynchronously. However, there are some limitations that we with any technology. Number one, bandwidth. So as we get the more data we collect, it's going to require storage, it's going to require transmission of that data. What is the data quality? So yes, we can oftentimes for example, I'll look in the ears virtually, and let's say the bandwidth is poor and the connection's bad and I can't clearly see the eardrum. So those can be limitations to what determinations I can make based on that exam. Security, so obviously a lot of personal data, HIPAA rules in terms of how we transmit this protected information. So if it gets into certainly the wrong hands, for example, that can affect people's ability to get insurance, etc. Technical support, so the more technology we use, the more potential challenges when the technology fails. So as we get more dependent upon it, we need support to ensure that it's working and optimal. Coding and billing, so as we're how do we get credit for the work that's done? And that will really drive, as we saw with the COVID and how the insurance companies were reimbursing, that will really drive sort of the growth from the provider standpoint, certainly, as well as the hospital standpoint. Licensing, and so this comes about when we look at providing care out of state. So most states are are the ones that control the licensing. And so when you're seeing patients in other locations, what are the rules of engagement for how you're allowed to see and or treat, given the different laws in the different states? Treatment disposition can be difficult sometimes if, um, depending on where the patient's located, having them come to your location, et cetera. And so that can be a challenge. And then obviously liability. So when the technology, you make a diagnosis based on the information you're given, but perhaps that was a wrong diagnosis. What's the effect on the patient, obviously, and then the potential malpractice that could occur. So moving on to the future, where do we see this going? Um, as we're collecting more biometric data, as we're looking as a smartphone as this tool to collect information, whether it's their hearing, whether it's the voice analysis, there's attachments that can occur that can capture all kinds of information. All of that can be synthesized into um, an AI type model that can review and even perhaps create a diagnosis before you even see the provider. The provider, the these tools can then be used to provide a certain percentage of care, and then the stuff that goes beyond can then be referred out to perhaps a global search engine where the patient puts out their information, and people, in a sense, they can bid on who's going to provide that care, who's going to make the diagnosis, and the patient can drive what they want done. There's AI chat GPT models for helping providers code better and be more efficient about seeing patients. So this could also be utilized to help create the notes. So as the encounter is occurring between the provider and the patient, in the background, the notes are already being generated, and there's some minor tweaking that occurs. And this will improve efficiency and really allow for the provider patient interaction to be paramount, as opposed to the provider concerned about coding or writing up their notes, etc. So lots of options. I see us in the future, especially with this growth of telemedicine, this expanding even more. There's some hurdles, as mentioned, related to kind of billing and coding and some of the legislative things that could limit it. But I believe that the technology is out there, and patients are going to, as we talk about disruptive technologies, but the smartphone truly, as patients are getting more information, are able to see in their ears and able to get more views. I think the growth will occur, and so I think we're just at the precipice. Thank you for your time, and that concludes my presentation.